And the reason I'm doing that is because in preparing or putting this symposium together, I actually wanted 4 speakers, and I know that's sort of a very rapid fire through different topics. Each of the speakers are really amazing experts in their field, and just in terms of way of disclosure, my expertise is in substance use disorders. I'm an addiction psychiatrist, but I've been interested in ADHD for more than 2 decades and have done research in that area, in this area of the interface of ADHD and substance use disorders. So I had the privilege of being able to put together this symposium, and I made my wish list, and I got the people who you're going to hear all willing to come. So I'm very excited. So I'm going to introduce each of them very briefly, and then have them talk, if they can, for 20 or 25 minutes. If they go a little over, we may not have time for questions after they finish, but hopefully we'll have about 10 or 15 minutes at the end for questions, depending on how this goes. Like I said, I sort of pushed in 4 speakers rather than 3, so it may be a little fast. So anyways, the first person that's coming to speak is Dr. Dougherty, Dan Dougherty. He's a William and Marguerite Wurzbach Distinguished Professor and Director of Neurobehavioral Research Division within the Department of Psychiatry at the University of Texas Health Sciences Center at San Antonio. He serves as the director of the Neurobiology Research Lab and Clinic and co-director of the Research Residency Program. His research interests are focused on understanding impulsive behaviors with primary emphasis on problems associated with drug abuse and suicidality. What I really liked about his work, and I'm going to actually talk to him later about this, is an extension of his research. He and his colleagues have developed behavioral software paradigms for objectively assessing underlying mechanisms of different types of impulsive behavior, which I think would be very interesting to study. And he said these paradigms have been validated in numerous studies and are actually freely available for other researchers. So I think that's terrific. So no further ado, Dr. Dougherty.
Okay, well, thank you for the invite to come here. I wasn't aware of this meeting. Today I'm going to talk about, so I only have like 20 minutes. I've been told that about 10 times, but I only have 20 minutes. So what I thought I would do, I started out with 60 slides. I'm down to 20, so I think I'm doing pretty good. So I'm going to talk about a cohort that we started about 8 or 9 years ago, where we looked at or collected kids at 10 to 12 years old, and mostly at risk for substance abuse. So they come from families with substance abuse. And we've been tracking them for, like I said, 8 or 9 years. As you might know, adolescence, pre-adolescence is the heightened period for risk for initiating substance use. This data actually came, I think, from, this is actually dated material, and as you approach or enter adolescence, 16, 17, you have this heightened risk for substance use. What's interesting about this graph and why I present it is it's very different from what we're seeing in our cohort in San Antonio. The most often used drug that we see is marijuana use, and this is the first drug of choice and the most prevalent drug of choice now. Alcohol is a second, and cigarettes or vaping, those kinds of things are very, very infrequent in our populations down in San Antonio. So what I'm first going to do is kind of give you a design overview and kind of highlight some of the characteristics of our cohort that we have. Like I said, 8 or 9 years ago, we collected 10 to 12 years old. They either came into 2 cohorts. Most of them were at risk, so predominantly family history positive. That's a FH positive that you see in the cohort there. And they had to have a father with at least 1 substance use disorder. The family history negative, or FH minus, which you'll see on all my slides, were a squeaky clean control group that we recruited, which was very difficult to recruit, believe it or not. Which we thought it was going to be the inverse, but it was really, really quite a challenge to get the family history negative folks in there. But so at the initial visit, we determined eligibility, did a structured clinical interview, family history, substance use, those kinds of things, a medical exam, some developmental sort of history, IQ testing, a lot of stuff on substance use. None of the kids had started substance uses at 10 to 12. and then SES sort of analysis. They come and visit us every 6 months, and they have been for a number of years. And we do quite a large battery. It takes anywhere from 4 to 6 hours right now. They come in with their, up until age 18, they came in with their parents. We have a whole host of measures on the parents as well that I won't really be talking too much about today. But we do the usual suspects: family history, medical exams, psychiatric assessments, a structured clinical interview, a lot of stuff on substance use, and a lot of environmental factors. That's what we did when we renewed this grant. We added a lot more environmental factors: peer, parenting, those kinds of things. But really, we predominantly were focusing on two processes: sensation seeking and impulse control. And we assess this in a number of ways. Most of the data I'm going to show you today is all related to self-report, mostly the Barrett impulsiveness scale, the BIS, and a sensation-seeking scale. These are the demographics of the kids that came in. Obviously, they're in between 10 and 12 years old when they came in. IQ was average for both groups. SES, there was a slight difference between the family history negative and positive group, but this represents sort of a skilled labor force, I guess, slightly on the professional, lower end of professional. ADHD was exclusionary for our controls or family history negatives, but 30% of the sample that came in with family history positive did have ADHD coming into the study. It's a predominantly Hispanic population. 70–80% of the sample is Hispanic. The substance use disorders, we were expecting maybe mostly alcohol use disorders, and a fair percentage of them had an alcohol use disorder, 75%, but there were large other cohorts too. Cannabis use and cocaine use was also elevated. We're lucky in San Antonio we haven't seen as much of the opioid sort of crisis down there. They kind of come from all San Antonio. The darkest areas there in the center there are just north of the downtown, right in the downtown area. And the distribution by zip code is kind of all over. South side is lower SES, predominantly Hispanic. East side is more industrial. The more affluent areas are just immediate north of the downtown area, and then sort of north and northwest. In terms of the parents that came in when we assessed them, they had a whole host of lifetime history of psychiatric disorders. Predominantly on the fathers, we had a fair percentage, almost 30%, who had antisocial personality disorder. On the mother side, we had greater incidence of depressive disorder, as you might expect here. But a number of them had multiple diagnoses there. If you look at the kids, boys and girls, break them down to boys and girls, here again you see a lot of different diagnoses. Predominantly on the boys' side, you have a lot of ADHD, disruptive behaviors disorder, oppositional defiant disorder. On the girl side, we see still a high percentage of ADHD and also some anxiety there as well. So really, when we started this study with the first grant that we had here, our primary purpose was number one here. What we really wanted to do is look at how impulse control related to substance abuse. So anybody can go get a cross-sectional cohort of substance users, measure impulsivity, and lo and behold, they're higher in impulsivity. But what we don't know is how they get there. Was it substance abuse that caused it, or was it pre-existing prior to the substance use involvement? So that's what the initial goal of the study was. When we renewed the study, what we did is we tried to extend to the dual systems model, and I'll have a couple slides about this, but really looking at the interplay between impulsiveness and sensation seeking and how those two predict subsequent substance abuse. So for those of you not familiar with dual systems model by Steinberg, it's important to note that the model was developed to explain normal adolescence. So, and this disparity between impulse control through adolescence and this peak in sensation seeking was thought to drive the things that you see out in the real world in adolescence and typically developing youth. So it's this gap here between the lack of impulse control and this heightened sense of sensation seeking that occurs during adolescence. Several years ago, actually my first postdoc, actually published a paper saying, well, can we apply this to explain mostly like substance abuse or deviant behaviors? So is there an exaggerated difference between this gap in individuals that might subsequently be related to whether or not people go on to use substances? So in this picture here, we have the solid lines, which might be typically developing youth, but in the dotted lines, we might have what we might expect in people who go on to do more deviant behaviors that are not typically developing. So we might have lower levels of impulse control development and heightened sensation seeking throughout adolescence. And the other thing we're doing is we're looking at this in the context of stressful life events, peer influence, parenting, family environment, and pubertal development as well. So what does this look like? This is data so far, and all this data has actually just been analyzed in the last 3 or 4 weeks. So I'm still kind of thinking about all this. But this is a function of family history. So this is from age 10 to 18, and this is impulse control measured in these same kids across time. And what you can see is the kids that come from the family history positive, the red line there, have less impulse control going into the study prior to drug use and less development of this across time. The significant differences, they become more disparate here, it looks like, in recent years. And typically, normally, it seems to be accelerating in terms of their impulse control development. So sensation seeking, this was a surprise to us, is really not different as a function of family history. This surprised us. We're not sure what this exactly means. But if you combine these things and calculate a graph, and this is sort of inversely related, so down is this larger gap, and based on the 2 previous slides, you would expect exactly this because sensation seeking doesn't differ. But you have this nice curve where the gap increases at age 14 and it's tightening up beyond. So what does this have to do with substance use? So again, just to reemphasize, what's driving that gap between the 2 groups is the impulse control. It seems to be driving these findings where sensation seeking and this is overlapping between the 2 populations here. So what does this have to do with substance use? So this is data that we looked at early initiators of substance use. So we took kids that by age 15, they have initiated any kind of substance abuse use. And then we went back and got their trajectories or the gap. This is that gap that we're talking about. We went and back calculated these gaps and plotted this. And so I'll walk you through this. But basically, the top 2 lines are non-users. And these are family history positive and negatives. They have less of a gap between these 2 important processes. What was kind of surprising about this is that the users, which are the orange and red, they start out different at early age. So at age 10 to 12, they are different in these 2 processes. And it doesn't seem to matter whether or not they come from the family history positive or negative group because these are both users and they both have larger gaps between these 2 processes. So I have a very bright postdoc who wanted to know more about the interrelationship between impulsivity and sensation seeking. This is data from another group, but this could be very well our data as well. But there are a lot of individual differences in how people get to where they go in terms of impulse control and sensation seeking, and it's quite messy. And the question is, how do these two things relate to one another to predict subsequent substance abuse? So he put together this model, which I thought was very clever. And I'll just kind of walk you through what the take-home message here is. So what he did is we wanted to look at how, on the left here, how family history status related to the frequency of marijuana use. Like I said earlier, marijuana use is the heaviest used substance in our group thus far. So he has those two on the end. But in between, he put two things. One, he put impulsivity at the early onset of the study. And then he put impulsivity as the development across 13 to 16 into the model. And the same thing with sensation seeking on the bottom. So there are two or three things to note here. One is family history status predicted, obviously as a direct effect, frequency of marijuana use later in adolescence. But interestingly, there was an indirect effect which was unexpected, where family history predicted impulsivity early on at age 13, but then in turn predicted sensation seeking, which then in fact predicted frequency of marijuana use. So there's this indirect effect. And I think this is important because these are thought to be two independent processes, and they're clearly perhaps not. I was kind of skeptical of this data, and then he went back with the alcohol data and replicated the same effect. So I'm fairly confident this is a real effect that we're seeing here. So some of the things that I didn't summarize in there are in this frame here. But higher levels of impulsivity at age 13 predicts sensation seeking at age 13. There were slower rates of impulse control development that predicted faster rates or higher rates of sensation seeking, which is a very interesting finding. And then family history status indirectly predicted substance use through higher levels of impulsivity and sensation seeking, like I said. So I will stop there and say that I'm not an ADHD researcher. I did look at a lot of ADHD stuff, trying to find if there were any relationship, but ADHD and family history positive basically overlapped in everything that I saw. They were the same curves, which was very interesting. But I'll stop there. Thank you. Oh, I can take a couple questions. I must have finished early. Any questions?
Hi, I have a question.
Sure.
So I was curious about, I'm Amanda Paley. I actually worked on this study early on. I didn't see you around, so I didn't get to say hello yet. But I was curious if you attribute any of sort of the separation you saw between groups on the impulse control measures to the fact that that's based on a really robust battery of digital tests, and sensation seeking is assessed by self-report.
In this, both of them were assessed. I used a sensation. Both of them were paper and pencil measures.
Okay.
Here, in this one.
For this one, okay.
The behavioral measures parallel this, with the exception of delay discounting seems to be the most differentiating and predicting substance use. But yeah.
Thanks.
Thanks. Okay, thank you.
As you all know, I think you'd have to be living under a rock right now to not know about the opiate epidemic that's has been a major issue for our country, particularly opiate overdoses. And surprisingly, there's not a lot of literature on the interface of opiate use disorder and ADHD, nor how to go about treating this. So I was really delighted that Amy was willing to tackle this and maybe talk more from a clinical perspective than hard research that's out there. But certainly it's an incredibly important area, and I think I will tell you, having worked in addiction for over 25, almost 30 years, that there's very little attention paid to ADHD, and often most treatment programs don't recognize or identify or treat it. So I think it's a huge issue and maybe a factor in adherence to opiate use disorder treatment, and without opiate use disorder treatment adherence, the rates of death are even higher. So I think that, Amy, it's going to be a very interesting talk. Amy, I got to know through actually an ACAP K-12 award that Kevin Gray, who's also one of the speakers, is one of the co-PIs on that, multiple PI on that, I don't know, whatever. But anyways, so and Tim is actually her mentor, and I co-mentor through the program, so we're all sort of incestuous relationship here today. But anyways, Amy is a medical director of the Addiction Recovery Management Services at Massachusetts General Hospital. She's an assistant professor in psychiatry at Harvard Medical School and board certified in adult, child and adolescent, and addiction psychiatry. She's the recipient of a 2016 Career Development Award from the American Academy of Child and Adolescent Psychiatry, funded by the National Institute of Drug Abuse, the K-12 that I just mentioned, and which she's evaluating medication treatments for youths with substance use disorders and severe mood dysregulation. So Amy, I'm delighted you're here.
The slides are there we go. So I'm excited to be here today presenting, and I'm going to focus on ADHD and opiate use disorders and think together about how we might best approach treating and assessing ADHD and OUD when they both co-occur together. So to start with, I have no financial relationships with an ACCME defined commercial interest, and some of my other activities are listed below. And today I'm going to quickly go through some of the background on the opiate epidemic, if you're not living in one of those areas that's been hard hit by the opiate epidemic, and talk about opiate use disorders and the treatment of opiate use disorders. Discuss the limited research that's out there on the OUD and ADHD comorbidity, and then discuss some of the clinical challenges in the management of OUD and ADHD in the substance use disorder treatment setting. So to begin with, as Dr. Levin mentioned, I think we're all aware that we're in the midst of an opiate epidemic in our country, and I'm just going to provide a little more background and detail on this. And one thing that's really important to know about the opiate epidemic is that opiates vary considerably in potency. And so some of the newer synthetic opiates that are coming have been kind of coming into the market, or the illicit market, are much, much more potent than morphine or heroin. And so fentanyl is 100 times more potent than morphine, and carfentanil is actually an elephant tranquilizer, and is 10,000 times more potent than morphine. And so if you expect that you're purchasing heroin, you think that you're using heroin, and you have a sense of how kind of potent heroin is and kind of what you might be able to manage safely in terms of your drug use, and you end up purchasing something that, unbeknownst to you, has fentanyl in it or carfentanil, you're at really high risk to overdose and die. And so it's important to kind of keep this in mind, and clinically when working with patients, it's really important to know what type of opiate they're using, if it's prescription opiates or these other synthetic opiates. And so how do we get here, this opiate epidemic? So basically in the 2000s, kind of late 1990s, early 2000s, there was an increased emphasis on pain management, in part with JCO and a focus on the fifth vital sign, which is pain. And so in response to this increased emphasis on pain management, there was an increase in prescription opiates to manage chronic pain. And what we saw, unfortunately, quite clearly, with kind of a retrospective lens, is that with this increased prescriptions with opiates for chronic pain, which are the top dotted line in this graph over here, which is showing you between 1999 and 2009. So with that increase in the kind of top dotted line, we saw a parallel increase in people being admitted for treatment for opioid use disorders, which is the bottom dark dotted line, and then a parallel increase in overdose deaths related to prescription opiates, which is the dark blue line. And so the hard part is we have an awareness now that kind of an potentially overprescribing of prescription opiates has led to this increase in overdose deaths, and there's been tremendous kind of resources directed towards increasing prescribers' awareness of this, increasing patients' awareness of these risks, and then resources to treat opiate use disorders. But unfortunately, we continue to see annual increases in overdose deaths, and this is showing you the number of deaths of people in the United States between 2002 and 2017. And I do want you to look kind of at 2015 to 2017, so you kind of see a kind of overall steady increase over the years, but particularly between 2014 to 2017, we're seeing kind of bigger jumps. And in 2017, 72,000 Americans died of a drug overdose death. So that's quite a few people. And so what we're seeing as this opiate epidemic has been going on is that it's actually evolving, which is making it kind of harder for kind of public health officials and researchers to kind of stay ahead of the game or try to get ahead of the game to make kind of make some impact in terms of decreasing overdose deaths. And what's been happening is that we've definitely gotten the awareness out there that prescription opiates are associated with increased risk for overdose, and we need to be thinking about different ways to manage chronic pain. So the consequence of that, though, is that as there's been decreased availability of prescription opiates, more people are initiating opiate use with heroin. And so this is showing you kind of different time points from 2005 to 2015, and this is for people who are entering treatment for an opiate use disorder. And when they're entering treatment, they were asked, what opiate did you first start with? And so you see in 2005, the top two medications that are listed there are oxycodone and hydrocodone. And you see between 2005 and 2015, that's overall decreasing. But you see a big, sharp peak of heroin starting to increase. So as you move from the early 2000s to 2015, with kind of, again, decreasing availability of these prescription opiates, people are switching to more illicit drugs like heroin and other synthetic opiates. And one concern about that is that's really been driving, the switch to these synthetic opiates is really driving the overdose deaths more recently. And so this is showing you drugs involved in US overdose deaths between 1999 and 2017. And you see that between, again, 2014 and 2017, when we saw the shift to people initiating opiate use with heroin, which is often contaminated with fentanyl or carfentanil, that we've seen this huge spike in overdose deaths related to those particular substances. So that blue line are overdose deaths related to fentanyl and carfentanil. And the green, the green line are kind of prescription opiates. So those are increasing, but nothing like the increase that we've seen in overdose deaths related to these synthetic opiates. And when we think about what are some risk factors for overdose, clearly opiates are a big risk factor for overdose, and there's been a lot of focus on risk factors related to substance use and characteristics of your substance use. There's been much less focus on psychiatric risk factors, and in particular, very little done on ADHD and risk for overdose, despite us knowing that impulse control is something that's very challenging for people with ADHD. And so there's been two studies, to my knowledge, that have tried to look at this a little bit. And one was done or published in 2009. And this study did find that individuals with a history of non-fatal overdose were 1.4 times more likely to have high impulsivity. And this is measured with the Barrett Impulsiveness Scale, which was mentioned in the prior talk. And then our group looked at an association, whether there was an association between lifetime history of ADHD and an overdose and young people presenting for substance use disorder treatment. We did not find an association between lifetime history of that ADHD diagnosis and overdose. But that being said, 61% of our sample had ADHD, so we had a very high kind of baseline rate of ADHD. And then we were also looking at lifetime history, so we weren't really assessing for symptoms of ADHD proximal to the overdose. So this is definitely an area that warrants further investigation. One, kind of generally this link between psychiatric characteristics and overdose, and in particular, impulsivity and ADHD. So I've been talking about a lot of kind of not so uplifting news and kind of reviewing that, but there's some positive news, and that is that medication for opiate use disorders really is important and decreases the risk for drug overdose death. And so buprenorphine is a partial agonist of the opiate receptor. It can be prescribed by people who have done additional training to get a waiver to prescribe these medications, which is referred to as an X license, and can be prescribed in the outpatient setting in outpatient clinics that are not necessarily a substance use disorder treatment setting. Methadone is a full agonist on the opiate receptor, and that is restricted to being prescribed for opiate use disorders in methadone maintenance clinics, where initially you do need to attend on a daily basis, and over time, if you're stabilizing, you don't have to attend as frequently, but it's a very intensive type of treatment. And then naltrexone extended release is a newer medication, FDA approved, I think, in 2011. That's an antagonist medication. It's an antagonist at the opiate receptor. So it's not activating the receptor and prevents people or decreases someone's risk for using opiates because they won't experience any pleasure or euphoria if they were to use opiates when they had naltrexone extended release in their system. So all three of these medications are FDA approved, and all three decrease people's risk of overdose death, and so are very, very important in the treatment of opioid use disorders. And so as we think about these medications, what are these medications, their effect on people's attention and cognition, especially as we're thinking about ADHD and OUD? And there's really been very limited research to date in terms of kind of assessing the impact of these medications on attention and cognition. And there's been no randomized controlled trials comparing individuals with an opiate use disorder who are on medication versus no medication. And it's really not totally fair or that meaningful to look at comparing people with an opiate use disorder on this medication to people with no substance use disorder, because these controls are very, very different. And relative to healthy controls without a substance use disorder, individuals with OUD don't generally have deficits in attention, cognition, are not functioning as well as controls who do not have a substance use disorder. And some of the reasons why individuals with an opiate use disorder might have some of these deficits include polysubstance use. So many individuals with an opiate use disorder have a co-occurring other substance use disorders or just have a high rate of other substance use. And then also toxic brain injury. So the way that you die from a drug overdose is due to respiratory failure. And so some of these people may have hypoxic or anoxic brain injuries related to drug overdose. So there's kind of been two studies that I was able to find that were randomized controlled trials really looking at this impact of OUD medication on attention, and I'm presenting the results of one of them here. And this was a randomized controlled trial looking at people with an opiate use disorder randomized to either buprenorphine or methadone and versus controls. And so they evaluated several different domains of attention and cognition. And one thing to note, so we talked about how polysubstance use impacts someone with an OUD's cognition and attention. 50% of the people with an opiate use disorder were actively using other substances during the trial, including cannabis, benzodiazepines, or opiates. And so in terms of the results, the one good news is that they assessed all these measures at baseline and then at 8 to 10 weeks. And so that individuals with an opiate use disorder on buprenorphine or methadone did show improvements in concentration skills and executive functioning between baseline and follow-up. But there was really no difference between buprenorphine or methadone when they looked at those two groups compared to one another in terms of these areas of attention and cognition. But when they looked at the people that were on buprenorphine or methadone versus controls, as I mentioned earlier, those with OUD did not do as well. So now if we switch to talking about OUD and ADHD comorbidity, we know that there are high rates of ADHD in SUD populations, and so about 4% of the general population have adult ADHD, and we see much higher rates in individuals with an OUD, so kind of ranging from 19 to 25% in two studies that I was able to find. In both of these studies, they were primarily done with men, and most of the participants were on methadone. And some of the characteristics that they found when they looked at individuals with an OUD and ADHD versus those with only an OUD were that people who had ADHD and an OUD were more likely to have a greater addiction severity, more comorbid psychopathology, and then poorer functioning, so much more likely to be unemployed. And when we look to treatment, there's actually only one study that I was able to find. It was done by Dr. Levin in 2005. And she did a randomized controlled trial comparing methylphenidate sustained release or bupropion sustained release to placebo in adults with ADHD and OUD who are on methadone maintenance treatment. And so this was a 12-week trial with 2-week placebo lead-in, 2-week dose titration, and 8 weeks maintenance. And it was a blinded double dummy procedure, so people got a tablet and a capsule both twice a day. And in terms of medication, there was some flexibility to titrate the medication, and so participants were on either methylphenidate were on methylphenidate 40 to 80 milligrams per day, or bupropion 200 to 400 milligrams per day. And then one thing that may have influenced the results, and may also influence results generally in trials with ADHD and substance use disorders, were that everyone who participated in the trial received CBT for their substance use disorder. And so, so they were receiving kind of additional treatment on top of potentially the pharmacotherapy and on top of the very structured treatment that they were receiving with the methadone maintenance. In terms of the sample characteristics, about 57% were male, 40% Caucasian, 40% Hispanic, and there was a high rate of co-occurring cocaine use disorders. So 53% had a co-occurring cocaine use disorder in addition to the opiate use disorder. And so what were the findings? In terms of the ADHD outcome, they looked at the adult ADHD rating scale, and you can see between week 1 to week 10 that all groups showed some improvement, and there was actually no separation between the active medication groups and the placebo group in terms of response to the kind of active treatments in terms of their ADHD outcome. And so the bottom line, or the bottom dotted line, are the bupropion group, and then the dark non-dotted line is the placebo group, and then right below that is methylphenidate. So generally, kind of all three groups improved in terms of their ADHD symptoms, and there was no difference between active medication and placebo. In terms of the substance use disorder outcomes, they looked at the proportion of weeks without any drug use, and generally across all three groups, there was a high amount of substance use in all groups. So not many people were able to stop their other substance use. And then in the current, the people who had a co-occurring cocaine use disorder, they continued to use use cocaine regularly throughout the study. So these medications didn't have an impact on their cocaine use or generally on substance use. But one positive is that there is no evidence of prescription stimulant misuse and no serious adverse events. So one thing that as clinicians we worry about is, what's going to happen if I prescribe them a stimulant or even any medication when they're still actively using substances. And again, there's no serious adverse events and no evidence of diversion. That being said, when they looked at the prescription stimulant misuse or diversion, these were patients that were being seen weekly, and so that potentially is a key component of decreasing risks for misuse or diversion. And so when we think about clinical management, there's a few things to think about and some guidelines potentially to follow. One is that it's really important to assess comorbidity. So we talked a lot about how patients with an opiate use disorder have high rates of other substance use disorder comorbidity. And in addition, it's also important to look at kind of comorbidity in addition to ADHD. And in samples where they've looked at patients with a substance use disorder and ADHD, people with the ADHD comorbidity are much more likely to have other co-occurring disorders than individuals with just a substance use disorder. So again, really kind of one basic priority is to know what you're managing and to assess for this comorbidity. It's also important to make sure that these co-occurring disorders are starting to stabilize when you're thinking about assessing ADHD impairment, since many of these different comorbidities also impact attention and focus. And the other thing to know is that therapy for substance use disorders is really important. And so a lot of people have a wish that if they take this medication, then and their ADHD is potentially treated, that kind of all the rest of the stuff is going to improve. And you have to be addressing the substance use disorder to really kind of make headway with both disorders when they're present. And then in terms of medications for ADHD, would consider starting potentially with a non-stimulant medication like atomoxetine or bupropion. And then if you are using a stimulant medication, it's important to use long-acting stimulants, which have a decreased risk for misuse, and to potentially involve a support person if possible that's helping with monitoring the patient's kind of adherence to the medication, monitoring for any misuse or diversion. And then also kind of principles of medication guidance, importance of safe medication storage, taking the medication as prescribed. And when we look at the prescription opiate epidemic or look at misuse of prescription medications generally, most people are misusing family and friends' medications for free. And so really important, if you remember one thing from my talk, is to be talking to patients about how they're storing their medications to make sure that these medications are not being used by other people. And then in terms of initial management, would recommend frequent follow-up and short prescriptions generally to make sure that they're staying stable. And so now I want to switch to kind of talking about some clinical challenges in managing individuals with an opiate use disorder and ADHD in the substance use disorder treatment setting. And I recognize that probably there's not as many people who are working in the SUD treatment setting, but I would encourage you to consider it since we need your advice and expertise and consultation. And some of the key components of a treatment plan for an individual with an opiate use disorder is therapy, as I mentioned, medication, structure, and then community support in terms of families, peers, living environment. And in terms of therapy, there are different therapy modalities. There's individual therapy, group therapy, family therapy. And if we think about how ADHD might impact these different components of a treatment plan, they can impact it in a big way. And often in kind of doing clinical rounds, I'll hear clinicians talk about, oh, that patient showed up late, they can't sit still, they're constantly interrupting, they asked to kind of leave group early. And so, that might be someone with comorbid ADHD who's, where the ADHD is not being treated, and really important to kind of not label them as not being motivated or not engaged in SUD treatment, but it might be related to their co-occurring ADHD. The other way that ADHD really can have a huge impact on someone's recovery or getting into recovery is it can make it hard. They may not be doing so well in school, may need more school support as they're trying to kind of get some structure, and they may also have increased difficulty with finding and maintaining a job. And so having structure is really important when you've gotten developmentally off track related to your opiate use disorder. The other thing to be aware of in terms of community supports is that medications with potential for misuse, including buprenorphine and stimulant medications, are often not allowed or encouraged by community supports, unfortunately. And so that's where we kind of need your help in kind of spreading education that these can be safe medications that are really important in helping people stabilize. And so mutual help groups are really a mainstay of treatment in that they're free, easy to access, and you're able to kind of interact with peers who have a goal of recovery. And so our clinic isn't open on Friday nights or Saturday nights, but these are kind of groups that patients can access for support of their substance use disorder on weekends or times when clinicians generally aren't available. The challenge, though, is, again, that these groups are not always as supportive of buprenorphine and or stimulant medication, and they're also fairly long, and they're often not very interactive. And so it can be hard for patients with co-occurring ADHD to sit and remain engaged in these self-help meetings. And then often when someone has an opiate use disorder, they've really gotten sometimes far off track developmentally or in terms of their functioning, and may need a more structured living environment to help them get stabilized in recovery. And unfortunately, again, most of these, similar to mutual help groups, most residential programs and recovery houses in the country are 12-step oriented, and so have this similar kind of philosophy or perspective. So in summary, medication for opiate use disorders is very important to decrease overdose risk. There's no major differences that have been identified to date between agonist medications at the opiate receptor, which are buprenorphine and methadone. And individuals with OUD and ADHD are generally sicker than individuals with OUD without a co-occurring ADHD. And then it's really important to identify ADHD when it's present for individuals with OUD, so it can be addressed as part of the treatment plan. I do want to kind of end with a few resources for people that are not kind of working as much in this field. So the Provider Clinical Support System is a free resource that's SAMHSA funded, where you can get free training, education, mentorship. If you're interested in potentially prescribing buprenorphine, you can have access to an expert for free who kind of coach you through how to do this. And then the STRTA consortium is a way that it's part of kind of some of this funding that's been directed to the opiate epidemic. And so in your community, if you're looking for more resources in terms of education or kind of guidance on how to set up services, you can actually get free kind of help and support with doing that through this STRTA. So you just have to do a request. So with that, happy to take one or two questions.
I'd like to congratulate you on a really excellent talk. There is one study that you cited, though, that I'm highly critical of, and I'd be interested in your thoughts or Tim's thoughts on the concept of trying to prevent or treat opiate overuse disorder with stimulant medications while people are taking cocaine. Now, if I'm not mistaken, I think cocaine and stimulants compete for very similar sites in the brain, and I'm just wondering whether or not you might have had more success if you didn't have all your participants using cocaine?
Yeah, for that particular study, not everyone was using cocaine, and I think Dr. Levin could probably speak to this. She's done a lot of work in this area, and actually, I think some people do view potentially stimulant medications as an agonist treatment for cocaine use disorders, if I'm saying this correctly, with the two national experts sitting in front of me. And actually, one of the few studies that's been positive in terms of using an ADHD medication to treat ADHD when co-occurring with a substance use disorder was done by Dr. Levin and was with cocaine use disorders and using higher doses of mixed amphetamines. So I think it's one thing, you know, in terms of thinking about if you're going to be using stimulant medications with someone with an active substance use disorder, you need to be following them very closely and really need to be making sure that you're kind of monitoring for diversion, misuse, and kind of seeing how they're doing clinically. So.
Tim's going to be talking about this also, so I'll leave it for Tim. But basically, if anything, having the cocaine use disorder, we had thought that group would do better. So one more question.
Yeah, just one more thing. I started working with Dr. Palazzi at the CDC back in about 2009 looking at this problem, and at the time it was much smaller, but still a clear major problem, and wrote a paper with him that I think came out about in 2011. That I think some of the stuff came out that you were talking about, but what's amazing is just how much worse it's gotten despite our efforts. And there's a lot of variability depending on your state and where you are, but I think the points you made are just absolutely critical. And when you think about 70,000 people dying and you compare it to like breast cancer, lung cancer, all these other deaths, it's way more than that for those conditions now. But I think checking and looking and seeing what's in the registry, educating, but I told some people already there was a tractor trailer in North Carolina that was going on I-95. They filled up the auxiliary tanks with fentanyl and carfentanil of a tractor trailer, one of the gas tanks. 158 pounds, gallons of stuff. And it comes in, but it's very widely available, but I think just educating families and patients and checking on it is really important. But it's very hard to know what to do, but I think it's getting worse instead of better because of the potency, for certain.
Yes.
And they're working on stronger stuff. That's the scarier stuff.
Yeah. So I think even if you're not working in this substance use disorder treatment setting or working with individuals with opiate use disorders more specifically, important to ask about kind of what's going on within the family, and then also important to talk to them about, again, safe storage of their medications, including prescription stimulants. So thank you.
Thanks, Amy. That was really great. I'm just going to give a plug again for PCSS MAT and the GET STR. I'm the medical director of both programs. It's SAMHSA funded, and it's a huge initiative. AAAP, American Academy of Addiction Psychiatry, is the lead site, but there's all the Data 2000 organizations, which are organizations that have been vetted to train people in buprenorphine, are involved, and there's like hundreds of organizations. We've trained hundreds of thousands of doctors. This is a big initiative that you may have no idea exists. And so I'd highly recommend, you now have an 8-hour buprenorphine waiver course. According to the legislature, you have to have 8 hours of buprenorphine training to get buprenorphine waivered, but it's free. It's totally free online. You don't even have to go anywhere for it. So there's really no excuse. Plus the PCSS has mentoring in your neighborhood. Wherever you live, there's mentors. So if you want to get trained, please go to that site. It's a national resource, and everything is free. So. Oh, great. So the links are going to get posted outside. You can do that. Okay, well, we can take it from Amy's slides, which Amy had, so hopefully we can do that. But if you have any questions after the talk, please come talk to me. Anyways, the next speaker is Tim Wilens, who's, I'm probably one of your biggest fans, Tim. I'm so glad you're here today. We're a mutual support system in doing this kind of research. Dr. Wilens is the Chief of Child and Adolescent Psychiatry and co-director of the Center of Addiction Medicine at Mass General Hospital. He's a professor of psychiatry at Harvard Medical School, and he specializes in the diagnosis and treatment of ADHD, substance use disorders, and bipolar disorder. He's widely published with more than 350 original articles, reviews, chapter books, and editorials to his credit. He's a consultant to the National Football League and Major and Minor League Baseball, the Bay Cove Human Services, and Phoenix Gavin House, and is consistently named one of the best doctors in Boston and in America for psychiatry. I've learned so much from him over the years, and I'm just delighted that he agreed to talk to us today. Thank you. Okay.
Oh, great. Thanks, Francis, and thanks everybody for being here, and thank you so much for organizing this program. This is such a hot ticket area. Actually, I'm going to be talking today about something that's really interesting. We've done lots of research in our group on treatment for ADHD, but we're also worried about the side effects. We've done a lot of studies on adverse effects, both short and long term, and this is one that most people in the room are concerned about, which is the non-medical use of prescription stimulants. Here's the disclosures, and I do want to comment that some of the companies I'm working with are working on abuse deterrent, lower liability stimulants. So this is right into the belly of the beast. I'm not going to be talking about those products, but just alluding to them as I go through here. I want to start by just saying, of course, once I took slides out, I wish they were in there. I always do that. I take slides out, and then I end up spending more time because they're not there. But I had slides of all the new stimulants, so I have all the new stimulants and all the durations and stuff. We're going to start with the assumption that the most effective treatments for ADHD pharmacologically are stimulant class agents. So for all the people who are non-stimulant psychopharmacologists or producers, I'm sorry to say that. I'm getting people flipping me the bird. I can tell what companies they're with. But what I would say is that they are the most effective. So the issue we have is how do we get the most effective agents into people safely? And what is the way to do it? And are there safety considerations from a substance use perspective? So that's sort of the starting part for where we're at. So let's start with diversion and misuse of prescription stimulants. And this just shows you sort of past year misuse of prescription stimulants. This is from 2015. There are so many data sets now on this that look that way. I've been working with the University of Michigan, and we look at it, and you can see they look very similar to this. And this just shows you, is that popping up there? You can just see where it's peaking. And no surprise, this is in college-age students. You can see a similar curve, lower, same kind of peak, opioids, but in non-college students. It's interesting. So stimulants, college-age students, and in the Northeast. That it tends to be in more competitive schools. So I want to talk a little bit about where they're coming from. And we have a recent study, and I'm going to allude to some of the work we're doing at MGH and University of Michigan, Sean McCabe's group. But I just want to point out, where are they coming from? Most of them are coming from family and friends, or from dealers. And we just recently saw that. So they're getting them from other people. It isn't true that they're getting supplies from you if you're treating college students. It's not people coming in routinely, not the all aggregate of them, scamming doctors. I think that's important if you're working in a college setting. Are there people who are going to scam doctors? Absolutely, but that's a minority relative to getting them from friends and others. And here you can see sources of non-medical use of prescription. Again, friend from the same school. This is by sex, and you can see there's no difference. Friends not from the same school, but still friends, and then it drops to acquaintances. So it's really coming from people like that. There are drug dealers, but that's a minority. And we've also learned from other studies, this is Ty Shep's work from the University of Texas, working with them, that a lot of where people get their medicines are extra supplies given to individuals. Turns out to be more of an issue for opioids. People know that. Amy's an expert on that. But for stimulants, it tends to be not in the person whom it's prescribed, but people tend to sell or give extra supplies that they carry, which is a lesson to all of us about sending kids to school with, we want to make it easy, so we're going to send you a 360 20-milligram Adderall short-acting tablets. You might as well just send them with a bank account to fill that, because that's what's going to happen to some of that medicine. Now, I want to show another important issue, and that is people with medicines are getting approached frequently. So this is those with stimulant medications are the most frequently approached to give up or give out their medicine, and that was something that Amy was alluding to. So you need to tell your patients who are on these medications that a quarter of them are going to get approached. You're going to get approached. Don't advertise it. It's not a stigma issue. We don't want people to know that you have these medications. And then you look at what's the percent actual diversion, and we actually showed this back in 2006. We were the first ones to show the level of diversion, and our rates were slightly lower, but look at the rates of how many people are giving or selling their medication. We found, in fact, that 22% were screwing around, but 11% had been selling their medication. These are patients that we were taking care of in our own clinic. Not anymore. No, we still did. We just... why is this important? Well, the stimulants on the street are increasing, and you're seeing a lot more emergency room visits and harm because of that. And Steve Ferrone has been presenting some data on that. So what are some of the characteristics of those who misuse prescription stimulants? First of all, this is not new. So Christian Teeter showed this almost 15 years ago. And that is that people are using them for performance enhancement. To help me concentrate or to focus better was almost 80%. Reduced distraction, 56%. And then there's some of the side effects of the stimulants to help you stay awake. Well, that's a side effect of the stimulants, and to get more energy, side effect of the stimulants. Most people who are misusing stimulants in the college setting, which is where it occurs, are using them to stay awake or for performance enhancement to help their focus and attention. It isn't really getting high. There's a percentage of them that do that, but most not. What are some other characteristics that are important? And I want you to think as a practitioner what you're going to worry about now if you know about stimulant misuse. Well, this is a really important one. And again, there are two ways to do these big studies. Some of that I've reported are survey type studies where you know a little about a lot of people, or you do what we did in the MGH study, which is we know a lot about a lot fewer people. So I'm presenting data on knowing a lot about a smaller group of patients. And when we torture these individuals with structured interviews and all these screens we do, you find that almost half of those people who use stimulant medications non-medically have a substance use disorder, and it's beginning earlier. So half have substance use disorder. It's an important number. That triangulates from all survey studies. The other issue is there's more multiple drug and alcohol use disorders in people who have stimulant misuse as opposed to just typical college students, so that you're seeing a more severe phenotype of substance use disorder in individuals who misuse stimulants. But it's interesting because now you're starting to say, or at least you're thinking, half do and half don't. So are these different groups? And we're looking at that right now, and the answer is they are probably very different groups. So we're talking about ADHD. What about ADHD? A lot of people say there's self-medication. First study out, a number of years ago, a guy named Himanshu Upadhyay, who I know Kevin knows from Medical University of South Carolina, talked about higher rates of ADHD symptoms. He didn't make the diagnosis of ADHD, but said more ADHD symptoms. We actually brought in individuals, and we find that, in fact, many of them have ADHD. But, in fact, that if you look on the axis, we've expanded it. 25 to 30% have ADHD, but most don't have ADHD. So it's not just simple, oh, we all have ADHD and we're using medications. We also looked at neuropsychological sort of functioning, and I'm presenting the behavioral rating inventory of executive functioning. And as Martha Dankla commented on earlier today, she mentioned that these don't line up particularly, and again, we find that all the time. But we found differences in both those who misuse stimulants and those who didn't. And the punchline was individuals who are misusing stimulants non-medically have higher rates of executive function deficits across the board, about a half standard deviation greater. About 30 to 35% of those who misuse stimulants would make criteria for an executive function disorder, as opposed to the controls, which is lower than 5%. So there clearly is a component of executive dysfunction that's in the majority of individuals who misuse stimulants. What are they misusing? In our study, you see mixed amphetamine salts, methylphenidate, and D-amphetamine immediate release. Immediate release, some extended release, and other in the unspecified. By the way, it's really interesting. We had pictures, we have names, we had everything. And yet people said, I took a stimulant, but I don't have any clue what I took, and I have zero idea of the dose of it. And we'll say, well, how many times did you take it? I don't know, 20, 30 times. So there's a lot of stuff people don't even have a clue what they're taking out there. Many people have seen this, but it's actually really really relevant to this. And this is older work by Nora Volkow. And it was looking at, I think, Alan, you alluded to sort of the link between cocaine and methylphenidate. And this sort of comes out of that. This is part of that same study. This is from the Brookhaven Laboratories. And they looked at uptake into the striatum of IV methylphenidate and oral methylphenidate. No surprise, oral methylphenidate has slower uptake into the striatum as opposed to IV methylphenidate. What you also see with that, which is not shown here, was that you can also see IV methylphenidate had much higher rewarding. You had more likability, even if you gave equipotent doses IV or if you gave it orally. And this lines up with other work that was done that looked at, in this case, D-amphetamine. Up here, you have D-amphetamine, intranasal D-amphetamine, where you see high likability of intranasal D-amphetamine. And if you look below here, you see with equipotent dosing, lower likability with D-amphetamine. So route of administration matters an awful lot with stimulants. And by the way, they know that too. This is an older study from Tom Spencer in our group. I love this study. It's one of my favorite studies. He stole it from me. But this is actually looking at equipotent dosing of Concerta, oral methylphenidate, and short-acting immediate-release methylphenidate. And you can see the binding in the striatum of immediate release versus extended release, and that this differed dramatically, both the percentage of saturation and the curves. And that translated, if you looked at likability, that immediate release methylphenidate versus equipotent extended release was this was a higher likability. There was more abuse liability with that. Here's I call it the Pac-Man study, George Bright's study. He looked at, in his clinic, and found 14% reported stimulant misuse. This is now individuals with ADHD misusing their stimulant. And here, that of those 14%, the short-acting constituted the greatest percentage of that. By the way, that's the same rate that Steve Ferrone reported this morning during the data blitz looking at misuse of stimulants. And if I haven't hit you over the head enough, I took out 5 studies, but I just want to show you this one because most people don't know this study. This is just looking at prevalence of single-agent misuse of prescribed stimulants as a function of their properties, long-acting, short-acting. And really what we want to look at is used with alcohol, got high, or misuse. And what you see is it's relatively high with the short-acting group, but if you look over here, that's missing from the long-acting. So bias, and I think most people here now know that that's one thing to consider. I saw Dave Baker over there, and Dave asked me to work with him on a project, and he said, don't you know that snorting is a big issue? And I go, it's not a big issue, Dave. It's really not. I work in the field. He said, can I send you some data to take a look at? This is before we analyzed our data, and I saw this, and I'm like, oh my gosh. So rather than go back to PubMed, I went and talked to a couple of my nephews who are in college, and I asked them, and they're like, yeah, dude, like everybody snorts their Adderall or whatever. It's common. And I asked them why they do it, by the way. And what's that? Somebody said something. And why they do it. And they go, because they're not using it necessarily to get high, but it gets them up for cognition faster. They don't like to wait that 45. These are very busy kids, you understand. They don't want to wait 45 minutes, so they can get the effect in 5 minutes, and they can study. So this was data just to show you, looking at large study, 40% were snorting and a group were swallowing. And of course, they overlap. There's some that do both. And we looked at the same thing, and we found our rate was 40% right on the nose. I was shocked that we saw the same in our study. I'm very interested in the group that's misused substances. So we're finding a lot of differences between misusers who have substance histories and those who don't. And I don't think it'll surprise anybody when you look at the rates of intranasal misuse. You see it much higher in context to anybody who has a substance use disorder. So why do we care about the misuse issues? Because the more misuse you have, first of all, the more problems you have in life. And if you're using it intravenously or intranasally compared to those who don't, that really is a signal that there's a more extreme problem. The other issue is, this is the effect of intranasal methylphenidate on subjective ratings. It gets you higher. Okay, wow, that's like Nobel kind of material. But you're going to get high when you start increasing the rate of absorption and the type of absorption. And we also see increases in things such as pulse and blood pressure. This is Stoop's lab that looks at this. So we start now more and more to see that. And when you look at the emergency room exposures, it goes way up when it's intranasal or intravenous compared to oral. And then finally, this is another reason that there are deaths associated with it. So this is just an N of 1, but it's something to think about. And in context, terrible things happened, but snorted crushed Adderall in this death of a University of Michigan student. We were interested in looking at this longer term. So this is looking at one of the monitoring the future follow-up studies. So this is 15 years later. So it's asking the question, if you misused stimulants when you were in high school and college, what happened 15 years later when you were 35 years of age? And what you find, let me orient you to this, is this looks at those who, with ADHD, who use their medicine appropriately. This is those with ADHD who use their medicine appropriately but were misusing their own medicine. And this is just a group of people who are misusing the medication. And look now at 35 years of age, looking 15 years later. This is the likelihood of having a substance use disorder. If you're right of this line, that means you're at increased risk. And just want to again show that medicated ADHD, which is what that is, was no higher than the population rate. So this is compared to those without. Those who were screwing around with their medicine and had ADHD were at increased risk for developing a substance use. And the highest risk was those individuals who were just kids out there misusing stimulant medications who were at the highest risk 15 years later. So it may not be so benign. By the way, I have to show this. This is only showing this because this got stuck into this paper. And I wish it were a different paper, and I should probably do a whole presentation on it. When people say we have no long-term data showing good outcomes in ADHD, that's not correct. This is 15-year outcome data on 8,000 individuals. This is looking at how many obtained an associate's degree or higher. This is the population control. This is people who are properly medicated or on medications for ADHD, who take their medicine appropriately. There was statistically no difference between that. A little bit lower, but no difference. The groups that did poorly were those who were screwing around their meds, had ADHD, or those out in the general population who were misusing stimulants. But I want to point this out. This is statistically no different, slightly less, which is what we would all expect. But when people say we don't have any long-term data showing things such as, we can also show occupational. I'm just presenting one side. And it's a whole different story, but I think this should have been a separate paper. So take a look at that. I'm happy to pass on these slides. They're online. Show that slide. I think that's important. So that I don't scare the bejesus out of everybody, I just want to remind everybody that stimulant medications, actually, especially the longer acting ones and well chosen in good populations and monitored, such as what's happened in Fran Levin studies, as well as these are two NIDA funded clinical trial studies. The punchline is, and you have the slide, is that we did not see abuse liability in high-risk populations when these kids and adults who had different disorders were monitored for their substance use or other things. So it's not automatic that people are going to have problems. And we're seeing that in the clinical trials, as Amy alluded to, that people who are monitored who have substance use disorders, who are on stimulant medications, almost ubiquitously extended release, they do pretty well, and we don't see misuse and diversion so much in that population. So I don't want us to get overly concerned about that. I think it's in context to good monitoring. So in summary, stimulants are frequently misused. It's more common with immediate versus extended release. Snorting and intravenous use is common, 40%. And the other thing I didn't get into is we also can show relatively high rates of stimulant use disorder. So they actually develop an issue. I think it's a myth. I started with it's benign and it's really just kids taking it orally to study for exams. There are a group of that, maybe half. But the other half, the problem is 50% of those who are misusing, there's other issues going on with them. We talked about the short and long-term adverse and things. And another take-home message is I think we need to educate, and I think that Amy really started that conversation with you about safe storage of medicines, not passing them on, ethical issues with handing them off. And by the way, if you get caught with a bottle of stimulants and you are selling them for $10, you sold it's $5 to $8 a pill typically, and you get caught because of the volume of stimulant and the milligrams that are in that bottle, that's a felony offense. And I've seen individuals get really harsh sentences for that. So warn your patients, the kids, that this isn't funny, don't hand it out, don't try to be nice that way to your friends. And the other issue is I really am a believer, particularly if we're using shorter acting stimulants, we need more abuse deterrent stimulants. We need to do better when it comes to these stimulants, particularly the shorter acting ones. And you heard a presentation during the data blitz today about a prodrug, dimethylphenidate, and I think it's encouraging to think about those and other ways to physically construct a stimulant to reduce that. So thank you very much. Okay, how about Alan?
Tim, you said over and over again that the longer acting preparations are less likely to be abused, but you never said one word about Concerta or Vyvanse. And is that because you never studied it or because you don't know?
Well, I don't try to use the brand names because the CME police come and put us in shackles. That was a joke, everybody. They don't really do that. They do it to Kevin, not to me. But it's really, they're quite different. So I think Concerta is an excellent one with that. You know, lisdexamfetamine they've looked at that, and they show pretty similar likability if you give it intravenously, intranasally versus orally, which is actually a win because people aren't going to do it those routes if it's really no different than taking it orally. Most of the studies that I was presenting were with orosmethylphenidate, which was Concerta, and partly because there were a lot of studies early on with it. But they have a lot of different studies with the different compounds.
Well, it was my understanding that Concerta had a osmotic delivery system that was non-dissolvable, and also that Vyvanse is not active until it's metabolized by the body. So can it be abused?
Yeah, it can. So you can, absolutely. And you can abuse. And when we look at our data, people are misusing and abusing. I don't want to give anybody the notion that the extended release, you're immune from abuse liability with extended release. They do get abused, but at a much lower frequency.
Thank you for taking my question, even though you don't know.
I'm sure it's going to be a great question. Very thoughtful, wisdom.
So I asked this question yesterday because it still fascinates me. Tom Spencer's work looking at methylphenidate's effect on opioid receptors on the perimeter of the nucleus accumbens. We've always grown up with the idea that the abuse here is a dopaminergic effect. And I'm wondering whether Tom has sorted this out to any greater degree. He used naltrexone to see whether the opioid was an ADHD factor, and it turned out not to be. But he didn't look at it in regards to the reward system. So I wonder if you could just comment, given your extensive psychopharm experience.
Well, it turns out it's Pradeep Bade who did that work from the University of Florida. And he found in animal models that he looked at stimulants and found that there was opioid activity. And most of that opioid activity was at the mu-opioid receptor. You know, you have 3 receptors in the opioid superfamily. But it was largely at the mu-opioid. And some, interestingly, at the kappa, which, by the way, the kappa is sort of they used to call it it's dysphoria generating. Yeah, dynorphin. And it would cause hypophoria. That was the term they used to use in the addiction. I kept saying that's dysphoria. And then so there's interest because if you stimulate that and cause a dysphoria, what happens if you block it? And that's some of the interest with naltrexone. But that's what sort of picked up on it, and that's what sort of triggered the idea is all of the abuse concern of stimulants linked to just dopamine, or as we know, is dopamine crossing and you see opiate activity, which is more and more what we see. You see a lot of opiate activity with purely dopaminergic agents.
Okay, thank you.
How are we doing time-wise? Okay, one more question.
Do we have any data in
Steve.
non-ADHD individuals that using stimulants to combat fatigue or to study actually enhances their cognitive performance?
Yeah, so the question is on performance enhancement. We're writing a paper on that right now. It's interesting, the early literature, Judy Rappaport really started that in 1987 with a paper in Science, and she showed an improvement across all classes of individuals using them. The fewer the symptoms, the less improvement, the more symptoms of ADHD-like, the more improvement. As we've looked forward into the more sophisticated neuropsych testing, what's that? Yeah, there's been some papers that are now disputing those early findings, and we're right now in the process of sort of putting it all into a Cuisinart and taking a look at that but the most recent papers don't show such a selectivity or it shows that it's really not in particular, and it's a very curvilinear dose response. So at certain doses, it may have some components, and then it reduces it. Betsy.
Is there data on misusers and whether they have higher comorbidities or higher suicidality?
The question is on comorbidity, and the answer is they do, and I cannot remember. So the misusers have higher comorbidity than the controls across the board. ADHD, conduct disorder, generalized anxiety disorder, major depressive disorder. Bipolar was low in both
Higher
groups.
than
The non-misusers,
treated,
compared to that.
Right.
And then when you look at the misusers who have substance use versus those who don't, no surprise, comorbidity always is going to aggregate with substance use disorders, especially in young people. So you see that's a much sicker group, put it that way. Okay, thank you.
Okay, and our final speaker today is Kevin Gray, and after Kevin finishes, we probably will have about 10 or 15 minutes left for questions. So if you have a question about either Kevin's talk or some of the former talks, we can bring them up again. So Kevin is a professor and director of child and adolescent psychiatry and professor of addiction sciences in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina in Charleston, South Carolina. With a multidisciplinary group of collaborators, Dr. Gray conducts NIH-supported clinical research, contributing novel advances to the treatment of substance use disorders in adolescents and young adults. Kevin serves as the chair, as you've heard already, from the advisory committee for the ACAP Physician Scientist Program and Substance Abuse K-12 program. In addition to maintaining his active clinical practice and research program, he's dedicated to education, providing didactic instruction across training programs, and he mentors, as I know, multiple junior faculty and trainees in clinical research. And Kevin, we're happy to have you. Thank you.
I want to thank Frances so much for inviting me to be here. She's taught me a lot over the years, and I'm also grateful to be with this distinguished panel. I was going to mention, actually, on Tim's talk, as I had mentioned, there's Karen Cropsey at Alabama Birmingham published a paper a couple years back with, I think it was young adults, and it was actually a clever design where it was, I think it was mixed amphetamine salts, where there was a placebo-controlled design where the expectancy actually drove the performance improvement better than the pharmacological effect. So people were told they were getting mixed amphetamines or placebo, but they also could have gotten mixed amphetamines or placebo, but it didn't necessarily match with what they were told they were getting. And the expectancy actually drove the effects, which is really fascinating. So maybe not completely surprising to the audience, but I thought the design was clever, and I'm glad the IRB allowed them to do that. Anyway, but it's a really fascinating topic in terms of whether there objectively is performance enhancement or not. So let me see if I can find, and hopefully it translates. Yay, okay, here we go. Appreciate you guys sustaining attention here late in the afternoon. My conflicts of interest are I do get funding from NIH for the research, and I'll discuss some of my NIH-funded findings. I have consulted for Pfizer on smoking cessation, but really nothing related to what I'm presenting today. And really, what I'm coming to this group with is I'm a child psychiatrist that happens to do addictions work, but I'm not an ADHD expert beyond just being clinically a child psychiatrist who prescribes for ADHD. So I don't claim expertise specific to the topic of this conference, but I hope to bring some cannabis experience to this group. And any cannabis-related... Sorry? Well, it's anyway, yeah. This is always a checkered topic, which is funny because I will start this with some navigating the cannabis information landscape, right? So this is an interesting topic, and I think it bears some mentioning in terms of just our information space around it. We'll talk about really what are the cannabis-associated risks, what's all the to-do about, and then how do we address cannabis use problems, and really then what are the latest on treatments, and how much of this relates specifically either directly or indirectly to ADHD. So on the information space, I think, and I know those who are present along with me at addiction conferences, I start with this often because I want to get this out there, is this is one of many polarized topics in our current information space. Cannabis is but one of many. And it's very difficult to address this topic without being polarized or being assumed to be on one side or the other, right? So you have, we did a great disservice to the public health, I think, decades ago when we sort of labeled marijuana as being this vile weed that caused people to murder and maim, et cetera, that there was this awful thing. But we've also done a disservice because there's the other end of the spectrum is where there's this this over reliance on this idea that marijuana is this wonder drug that's good for everything, right? So it's dangerous for us to vilify any substance as being absolutely toxic for everything, but it's similarly dangerous for us to say that it's a panacea and good for everything and that the government's been suppressing information that it cures cancer. Both of these things are dangerous, and it actually kind of poisons the information space. So what I want to sort of get at is this also gets into our clinical encounters, because when we caution our patients about cannabis, oftentimes we can be framed as being prohibitionists, or that we're on the side of the devil's harvest, we're on the side of reefer madness. And what I would like to do is disarm some of that and remind ourselves is that we're coming at this from different perspectives, right? So we come as clinicians with a perspective around, well, we're cautious and worried about substance misuse, but people may genuinely, with good intentions, come to you with having heard somebody down the street said they started using CBD oil and it was really making them feel better, so they're asking you if they should use CBD oil for their ADHD, say. And we ought not fall into that polarization either intentionally or unintentionally. So just thinking about those perspectives. And when I think about a topic like cannabis, I re-embrace something I learned back in science classes about duality. You know, it sort of blew my mind as a kid is to hear that light is both particles and waves. Those should be mutually exclusive, but they are simultaneously true, and that's okay. And when we think about this as it regards to cannabis, is that it may not be all good, it may not be all bad, and that's okay. But let's kind of try to navigate that situation to situation. It may be different, and we may not know everything yet, and that's okay too, and that's part of the fun of science is we get to learn more. So let's embrace complexity when it comes to cannabis. So cannabis can be potentially safe and benign. It can contain potentially medicinal components and also be potentially risky and harmful. They can all simultaneously be true, and we can manage nuanced messaging around this. And I really think is that we have to personalize that message based on what's being presented to us in a clinical encounter. And so it may not be a blanket statement to each patient or each family that we speak with, but let's sort of characterize what their risks and what their benefits might be and frame the discussion in that way. So first, what do we know about its benefits, right? So any good motivational interviewer knows that if you're speaking with a substance user, you first really want to ask them what they like about their substance before you start asking about all the bad, especially if it's a young person that's coming to you because they've been dragged by the ear to come in and talk to you about their substance use. You really want to understand the context of the use and what they like about it. So cannabis-associated benefits, now this is a whole big world that's broad in terms of what do you like about using cannabis from an abuse standpoint or cannabinoid medication. So there's a broad topic here, probably not easy to fit into a 20-minute presentation. This is just supposed to be the intro, so bear with me. So there's evidence of therapeutic roles of specific, reliably dosed, orally administered pharmaceutical-grade cannabinoids for specific conditions. So that's the pharmaceutical part. That's been conflated in this larger term of medical marijuana, right? But all the evidence really is around oral THC, which has multiple indications and is readily available. And then now the new kid on the block, which is cannabidiol or CBD, which now the pharmaceutical-grade version of that, Epidiolex or Epidiolex, I don't actually know how it's pronounced correctly, but GW Pharmaceuticals has now had that, and it's actually rescheduled, and so it doesn't have all the Schedule 1 restrictions with it, and that's now indicated for intractable seizures and Dravet syndrome and Lennox-Gastaut syndrome. So there is evidence of specific cannabinoids, but that doesn't mean that all of smoked cannabis is good for everything. And there may be times when the benefits are outweighed by risks, and that's where we get into the ideas that let's talk more specifically about what you're getting, what the cannabinoids are, and more specifically about who it is and what is their level of risk versus benefit, right? So if you have a specific syndrome that has intractable seizures that are not responsive to the baseline usual treatments, you may be a good candidate. Maybe it's worth the risks. For someone else, it may be different. In terms of risks, I think this is important, and I think it's actually important to frame this alongside what we have. So Dr. Yule was speaking about opioids, which have a massive risk for very serious consequences, and the rates of use are much higher than they had been before. With cannabis, it's a little bit of a different picture because the risks of use are perhaps not so immediate and dire, but the prevalence of use is so much higher that we have to sort of think about both of these as different things. So the first is intoxication. One issue that at least anecdotally I hear from my colleagues in Colorado is they're more careful on the roads because of legalization has really changed what the roadway looks like, and there's data to back that up in terms of the frequency of motor vehicle accidents with cannabis use. There's good laboratory data showing driving performance is impaired by cannabis use. And if you combine alcohol with cannabis, there's more than an additive effect of the two together. And then when we get into chronic and repeated dosing of cannabis, well, cannabis use disorder is a real thing. I've spent the large majority of my career really focused on working with people with cannabis use disorder. This is not the occasional weekend user. These are people who, even in adolescence, are using frequently, daily, at heavy doses. And it's more prevalent than we previously thought. So a fifth of lifetime users, and of those, a fifth of lifetime users with cannabis use disorder, about a quarter are symptomatically severe, so they have enough symptoms to be in the severe category, and of those, about half are not functioning in any role. And so we minimize, sort of when we talk about, oh, well, cannabis is safe and benign, it's really not such a big deal, is of these people who have cannabis use disorder, this is a serious problem, and clinically, they have a very difficult time cutting back and quitting. And treatment outcomes really are, so with the best of treatment, most people do fail treatment. Use during pregnancy is a big concern. One of our worries about, especially with dispensaries where people are getting sort of anecdotal feedback from people, is it's actually being recommended by some dispensaries to reduce nausea and pain during pregnancy. And there's very clear animal data in terms of harms, developmental harms of cannabis use during pregnancy. And then really near and dear to my heart as a child and adolescent psychiatrist is the exposure during childhood and adolescence with cannabis is a very serious problem. So about double the rate of developing cannabis use disorder. And then there are adverse effects which really affect the main developmental goals of adolescence, so cognition, emotion, and development. And so we'd be particularly concerned about our ADHD population when it comes to cannabis. Well, a couple of things I think are to bear in mind on this is that childhood ADHD predicts earlier cannabis use onset and escalation to frequent and heavy use. When we talk about adverse consequences of cannabis use, it's not typically the occasional user that winds up with these consequences. It's the heavy, frequent users. It may not be surprising that childhood ADHD predicts this higher level of use. So, and there's a couple specifics in here. So, and Tim is a world expert on this, is trying to distinguish how much of this is driven by ADHD versus co-occurring cognitive disorder or ODD. There are distinct parts where it's just the ADHD driving this, and there are some specific things within that I think that bear in mind. Again, I won't read all of this slide, but in addition to the childhood ADHD, if you look at young adults with ADHD versus those without ADHD who are cannabis users, they're more likely to sustain heavy use. So this is a kind of a recurrent theme if you look at cannabis use and co-occurring psychiatric disorders in general. Those who are heavy cannabis users wind up having a worsened course of their psychiatric disorder. Now, what do we do for cannabis use disorder? I'm going to focus on youth. I know ADHD occurs across the lifespan. I'm a child psychiatrist, so my bias is toward talking about young people. Some of these things should be familiar to all clinicians, so motivational interviewing or motivational enhancement therapy, really like meeting the patient where they are and helping them with sort of nudging toward a behavioral change over time. Using cognitive behavioral therapy, so really some nuts and bolts in terms of what we do with CBT, translates across conditions, including substance use disorders. There's a variety of family therapy modalities that are effective for cannabis use disorder. Probably too detailed to get into the specific modalities for this brief presentation. And while these treatments are valuable and effective, if you're looking for abstinence outcomes in the long term, we're really very modest. We have a long way to go. That frustrates me as a clinician, as a researcher. It leaves it wide open to keep doing more work. And then one thing, behavioral treatment contingency management, which I don't know if it's as well known in the ADHD space as it is in the substance use space. This is operant conditioning, rewarding desired behavior. And so with contingency management, in its most basic form, is providing a token or reward, say for a negative drug test. And so we find that if you add contingent rewards to usual treatment, it enhances the outcomes, particularly in people who may have ambivalence about behavioral change. If you give an external driver of a behavioral change, that may drive that change, and then if they get experience without using, they may then internalize those rewards over time in theory. So CM is a good way to enhance outcomes, and so even if it's just natural rewards that can be delivered by parents, it's something that enhances outcomes. And then a lot of my team's work is really around medications to complement psychosocial treatments for cannabis use disorder in young people and in adults, and Francis has really pioneered the work on pharmacotherapies for cannabis use disorder. So I'll talk briefly about one compound that we've studied, N-acetylcysteine. It's sold as an over-the-counter supplement, and it's thought, at least in terms of substance use disorders, to target glutamate dysregulation in the nucleus accumbens, and it activates the cysteine glutamate exchanger, upregulates the GLT-1 receptor, and by doing that behaviorally, it reduces reinstatement of drug-seeking animal models, and which is sort of a fancy way of saying essentially the idea is that it normalizes neurochemical pathology that occurs with repeated substance administration. It normalizes it in a way that then changes that behavior and reduces drug seeking and reduces reinstatement of drug use after a period of abstinence. And so we initially were I was curious about this because I saw it as a low-risk compound, and we just did a proof of concept study with young cannabis users. Looked like it was well tolerated. They were willing to take the compound. And then NIDA funded us for an adolescent NAC trial. So this has been a few years back now. So we had 116 adolescents randomized to NAC or placebo, 1,200 milligrams twice a day. And all of them actually got a pretty intensive course of psychosocial treatment. So they had weekly cessation counseling by the medical clinician, usually me. And they also got contingency management, so we actually gave them cash rewards for negative urine drug tests in escalating fashion. And so they could really get pretty strong rewards for negative drug tests. One could criticize and say that's too strong a treatment, but if you look at the results, it wasn't too strong a treatment and actually still gave us an opportunity to see med versus placebo response. So again, I'll try to summarize this as best I can. So the x-axis is the week in treatment. We had 8 weeks of active treatment, then a post-treatment follow-up 4 weeks thereafter. And then the y-axis is the percentage of negative drug tests at that given week. This is an intent-to-treat analysis such that the denominator is always 116. So even if somebody missed a visit, we assume that they were using and assume they had a positive test. So this is a very cautious, conservative estimate of our outcomes. The first thing I would say about this that's interesting, the dotted line is for the placebo group, is that, again, cash rewards for negative drug tests, and still only about a third managed to get a negative drug test with cannabis. This is complicated because it takes a while to get a negative test, even if you've abstained. It's sort of a long story. But what was encouraging about this is here's a medication that was quite well tolerated, where we saw a notable effect that was detected early and sustained throughout active treatment. Some evidence numerically at post-treatment follow, but we weren't powered for that. But we were encouraged at this because it really seemed to be something that was a nice, safe add-on treatment. Some secondary things that bear sharing with an ADHD audience is that cognitive task performance improved with cannabis abstinence. So not a surprise, one of the problems with cannabis use is cognitive impairment. And there have been longitudinal studies looking at cognition and whether it improves over time, but very few that look at in the course of acute treatment do you get impairment improvement. And so we were encouraged to see task performance improvement early. The other thing is looking at impulsivity. So we're interested in this as a marker of treatment response. So not surprisingly, those who had low impulsivity and high medication adherence were the ones most likely to become abstinents. That said, it was really interesting. If you isolate the high impulsivity people who actually took their medications, they had the most benefit in this study. You know, the sort of the rare unicorn that is impulsive but takes their medications did really well. And so if you target this condition of high impulsivity and you really enforce medication adherence, maybe they stand to benefit really well. Also more effective with elevated depressive symptoms. So it kind of gets at this idea that maybe it's targeting something along this sort of psychological pathway that may mediate some of their cannabis use. And so a couple other secondary things in there. And then we did a subsequent multi-site study in adults with cannabis use disorder with discrepant findings, to say the least. So very similar structure, but this was 12 weeks of active treatment, the same platform of psychosocial treatment, and a very different profile here in the adult study. And so this is the same x-axis and y-axis, and so the adolescent study, I think, was an odds ratio favoring NAC over placebo of 2.4. In the adult study, it was 1.00. And I will forever etched in my brain is when I was talking to the statistician and she said 1.00. That is a true marker of no treatment effect at all. And so I was initially crestfallen, and then I progressed to sort of think about what the heck might be happening here and why would it be so different? We really took great pains to structure this similarly. Again, probably a topic for another day, and we speculate about in the published findings. One thing I know Tim and I have talked about is one of the first things I looked at is, hey, we have an age overlap. Our adolescent study went up to age 21. The adult study went down to age 18. What happened with the youngest participants? And while we weren't statistically, we certainly weren't powered to detect this. This was not significant. But if you actually parse out the 18 to 21-year-olds, it looked like there was at least a numerical effect favoring NAC over placebo, such that perhaps the young people earlier in the course of their cannabis use disorder might be most responsive to this pharmacotherapy. So, you know, we can only speculate as to whether we needed to dose higher for adults, a different platform treatment, or maybe NAC doesn't work in those with further progression, but that's all speculation at this point. We're currently doing a follow-up trial with adolescents now, kind of a replication trial, so we're about halfway through enrollment with that trial now and data collection. Moving on to some other data around cannabis use disorder specific to co-occurring with ADHD. This is Paula Riggs's work, and this has been a few years back now. She did a placebo-controlled trial of oral methylphenidate, or brand name Concerta, a multi-site trial through the NIDA Clinical Trials Network, 303 adolescents. Most of these did have had cannabis use disorder. So it was general to substance use disorder, but most of them was cannabis use disorder. And they had their primary outcomes were self-rated ADHD RS and days of substance use, and there was no med versus placebo difference in those primary outcomes. However, the secondary outcomes were positive, both in terms of parent-rated ADHD RS and in terms of number of negative urine drug tests. And I actually thought those secondary ones were actually pretty important markers clinically. There was a similarly designed study. Chris Thurstone, also at Colorado, did a similarly designed study with atomoxetine that was a null finding. It was a smaller study. I was mostly encouraged by this oral methylphenidate study. I spent a lot of time speaking with clinicians who understandably are cautious about prescribing in the context of ADHD and substance use disorder, right? So there's the clinical conundrum, right? So to treat the ADHD, I may have to prescribe something that may potentially be abusable, and so I just won't do it. So people sort of want to close their eyes and ears and not do it. But at the same time, we know that we may be making it more difficult for someone to respond to treatment for substance use disorder if their ADHD goes untreated. And so I think this line of research is really important as to looking at trying to treat these concurrently and hopefully yield an improvement. So at the very least, if you can take away that there's good tolerability and maybe some secondary suggestion of a positive effect, I think that's very encouraging. It's enormously difficult to do this co-occurring treatment research, and I'm looking at 3 people who have conducted a lot of this work. It's very hard to get these samples and keep them in studies and also, kind of follow guidelines with this. So the summary on this, and again, I apologize, I sort of scattered in a few different places with this. It is a complex topic when we talk about cannabis in general, and then if we try to parse it down to ADHD, and then we think about different age groups, et cetera. But what I really embrace this idea when we want to talk about cannabis with young people and talk about it with families is it's a complex topic, and that's okay, and it's worth discussing. Let's try to avoid falling into polarization. It's really hard to do it sometimes because sometimes it's so frustrating. I have adolescents often come to me and say, the weed is the only thing that helps me focus, and it's treating my ADHD, and I'm doing better with it. And, and I'll have objective evidence based on grades that really refutes that. And I really want to get into an argument about it, but it's not the best way to go at it. It's you sort of embrace the complexity and be okay with it. We can be excited because I'm excited about cannabinoid pharmacotherapy. I think there's a lot of medicinal applications of cannabinoids. I think that's great. At the same time, we also have to be cautious about particular patient populations with cannabis, particularly among youth with ADHD. I think I hopefully made a reasonable, persuasive argument that young people in particular are at higher risk with cannabis use, and those with ADHD are at elevated risk beyond that as well. So mainstays of cannabis use disorder treatment are motivational interviewing, CBT, family therapies, and CM, or contingency management, can enhance outcomes. We did have a positive finding with NAC as an adjunct in adolescents, but not in adults, and that story is still an open story. We're refining and doing another adolescent trial. Treating co-occurring ADHD and cannabis use disorder or oral methylphenidate appears well tolerated with some secondary indications of benefit for both conditions. And it looks like there's a line for questions already. Great. Thank you.
Thank you.
Start with Tim and Amy go in front. The questions are probably mostly for Kevin right now, and that's great. But then after that, we have like 20 minutes. So after that, we could answer any other questions that the other speakers. So.
And credit to Dr. Levin for keeping us on time.
Does that mean I get 10 minutes to ask this question? I'm kidding. I don't know if the rest of you get mailers from everybody and emails from all kind of services telling you new things, abstracts and whatever, but just 2 days ago, I got one about something with cannabis 1 or 2 times in an adolescent left a permanent marker that was negative. And I don't remember the author or where it was done or anything, but that was the distinct message. So, and that even makes me worry big time because a lot of people would be doing it experimentally just to see how they feel or just because their buddy talks them into it or whatever, if it's really true. So that was one question. And then regarding the NAC, I just want to throw in there too, I know it's one of the top treatments for trichotillomania. I also know it's used to augment OCD treatment, and I'm wondering about whether you think there's a role for just that being an evolving new drug we do a lot of research on and think about it in various ways and try to understand its core mechanisms, et cetera.
Okay, so thank you. So two different areas. One is actually, we just had Hugh Garavan at University of Vermont gave a talk at our university last week. He's a neuroimager. He's involved in the ABCD study, which we have a site at MUSC, which is a longitudinal study of about 1,200 children ages 9 to 10 that are going to be followed into adulthood, doing serial neuroimaging, neurocognitive testing, psychosocial assessments, et cetera, which is going to really allow us to parse very clearly amongst those who start using cannabis or other substances early, whether they're either brain or behavioral markers of differences. He actually has some prior evidence from the Imogen study, which is a consortium study in Europe using neuroimaging of very early first couple of drinks outcomes with alcohol in adolescence that are notable and significant. And so there may be some of this early change stuff. I think we're going to be much more powered to answer these questions as the ABCD cohort gets older. So more to come there.
This particular abstract did mention and I think the NIH evolving pruning mechanism in adolescence and how the adolescent brain is very different in the sense that it's evolving and changing and developing.
And then on to the NAC or NAC is, there is, so Mike Burke in Australia is the lead researcher around looking at NAC for mood, psychosis, a number of other conditions, and we certainly know there's other researchers doing it around obsessive compulsive disorder and other compulsive behaviors. Yeah. Their mechanistic hypothesis is more around the general antioxidant effects, whereas the mechanism in addiction has been focused. So Peter Kalivas, a neuroscientist at my institution, MUSC, has really focused on glutamate and the accumbens. I think there may be some of both, and I certainly see NAC as it pertains to substance use. My clinical impressions are that it really does reduce drug seeking and such that sort of people who compulsively seek out the drug, it can reduce that edge of that aspect of their drug use. And so the anecdote I often use is a college student that I treated who sort of without thinking about it was no longer buying cannabis. He wasn't going through the trouble of going and buying it, but if he was at a party and somebody passed him something that was really good, he would use it and enjoy it, but he wasn't seeking it anymore. And so I think that has some overlap with compulsivity, which also overlaps with hair pulling, skin picking, and so I tend to use it for some of those compulsive behaviors as well. So there may be something that joins these, but there's lines of research going on about it. It's got all the complications about something on this non-FDA regulated as a supplement, so there's some challenges as to where you get the supply, but again, I'm stealing time from other questioners, but thank you, sir.
Thank you.
There's this increasing number of the endogenous endocannabinoids. It's turning out that the cannabis, we talk about the CB1 and the CB2 receptor, very complex system. Do you have any sense, or is there any consensus about what this system is doing in the brain?
Oh, sure, gosh, and so I'm just old enough that I didn't learn about the endocannabinoid system in medical school, so I think that officially makes me old. And I've double-checked with medical students, they learn about it at least briefly. So the endocannabinoid system is involved in development, in immune response, appetite, mood. Those are kind of the four areas that we most think about. Some of it makes sense if you think about effects of exogenous cannabinoid administration. One of the concerns is that if the endocannabinoid system is so involved in neurodevelopment is that it's probably really problematic if we interfere with it during critical stages of development. That's why there's worry about in utero exposure and also worry about exposure during childhood and adolescence. So the immune response part, so there's CB1 and 2 receptors, both centrally and peripherally. It's the topic for like probably a lot more time. And
I was wondering if that would be a topic worth exploring in this symposium next year. I think if people can put that on their evaluations, but it seems we talk about this system without really acknowledging its complexity.
Yeah.
It's found in the hippocampus, CB1, CB2, so it must be involved or implicated with memory. I mean, there's a lot of things that it's doing that we don't really know much about.
Absolutely, thank you. Yes, sir.
About 4 years ago, I successfully treated a 14-year-old who was using pot on a daily basis for generalized anxiety with sertraline. And I followed him for 4 years, and he remained mostly anxiety-free, but absolutely refused to stop using pot on a daily basis. And I didn't argue with him about that. You know, I wanted to maintain a relationship with him. And this is a question for all the panelists. Unfortunately, 2 weeks ago, the police took 4 pounds of pot out of his house, and despite the fact that he's in college now, he's gonna have a big legal problem. So my question for you is, this is a clinical question that we all deal with. If some adolescent has no motivation to stop using pot, any suggestions? Do we have a magic pill?
So it's funny, actually, I usually include, so I also had to pare down my slide significantly. I actually have a slide that says, there will never be a magic pill. So that's my response number one, unfortunately. I think the other part is first motivational interviewing. It's not a magic cure. It's a slow, gradual process. But I think it is the friendliest process at trying to drive it at motivation for change, and it comes in fits and starts. The other is the potential for external incentives to initially change behavior even for an external driver, and to see if they then internalize benefit. So the idea is that with a system of contingent reward, if somebody experiences abstinence, what do they feel like? They may not actually like the feeling of abstinence. Now, early on, you may be in withdrawal and really not like it. But if you get into months of abstinence, is life different? And so, you know, with MI, oftentimes with college students, it comes down to grades or comes down to money. Money is actually a big one, is that they wind up using so much, it costs them a great deal. I would guess that if he had 4 pounds of cannabis, is that he had moved on to a financial transaction he was dealing as well as using. And part of that was probably to drive his own use. So I don't have an easy and quick answer, but what I would say is the answer, we are so prone to wanting to combat it quickly, and the answer is much more in the idea of finding them where they are and trying to help work with them on what might be a little tiny nugget of behavioral change motivation and work with that.
As an anecdote to what you're saying, I had a patient in my practice for 2 years.
Are you talking to Mike?
Oh, sorry. I had a patient in my practice for 2 years, and I always was struggling with, he continued to use marijuana, not maybe at the extent that your individual was, but I was treating with Concerta, and I thought his ADHD was getting better, and I sort of stuck with him, and I felt like, God, his parents who were helping pay for his sessions, I was thinking, oh, they must think I'm a failure because, you know, the kid is still using and whatever. And then 2 or 3 years later, he went back to Washington, where the kid was from, and I got the parent I ran into at some meeting or wherever I was at, and the family member, the parent said to me, you know, he's doing a lot better, and he's actually reduced his use, and all that time you spent with him really made a difference for him, and I felt I wasn't doing anything. Now, in this case, unfortunately, you know, the kid got arrested, and it's a different story, but often, like Kevin's saying, it can take years, and sort of sticking with them, and at least I was treating his ADHD, and when he did go back to Washington where he lived, it made a big difference. So I think getting nihilistic or feeling, oh my God, this, you know, they're using drugs, or, you know, I mean, if they're heavily into drugs, you got to deal with that. But if there's not having consequences, I think treating the ADHD and hoping that over time there'll be a change sometimes work. You know, unfortunately, when you do clinical trials, it's 12 weeks. If you don't get an effect in 12 weeks, you think, you know, it's a failed trial. But often it's sort of ridiculous. I mean, we should be funded for, you know, 2-3 years, and often the changes are much slower. And I think that's part of the problem, because that's what clinicians see. What we do in a research is very different than what you're seeing. So.
I'm just going to be a little more specific. When Kevin said external reinforcers, I want people to be thinking about caregivers and parents. And one thing to consider, though, is that it's very difficult as an individual practitioner to engage the kid motivationally while also coaching his parents, coaching the parents on contingency management. And so often that's where a team-based approach comes into play. And so in our program, we have providers in parallel working with the kids and the parents to help increase the kids' motivation to make a change by teaching the parents about contingency management. So.
And that gets into the idea of drug tests being an opportunity for reward rather than an opportunity for punishment. And so that's a whole other interesting topic, is around the idea of using drug tests in treatment. They can be very valuable, but we quickly have to really work with parents on the idea that a positive test is expected, a negative test is a reason to celebrate and reward. And then, of course, not being naive and knowing about ways that people can adulterate their specimen, et cetera. But anyway, again, I want to open up for the whole panel, and I know we've got some more.
I really enjoyed your talk, and all the symposium was wonderful. But particularly what I wanted to thank you for saying is we get stuck in this game of good boy and bad boy. Like, is Pod a good guy or is bad guy? And generally, one of my models is if the patient uses the word dude, I'm always a little more careful. But, and that's because I'm from Canada, and our Prime Minister uses that word. Dude. In Canada, on October 17th, cannabis is completely legalized. And what I've watched is with the development of medical cannabis and now the legalization of, there's various terms, but one of my patients refers to it as fun pot versus medical pot. And I always thought that was great. But the point I wanted to suggest to you guys as you talk about it is you have to be really careful when you go, well, multiple substance of abuse. And the reason I suggest this is I have patients who are cannabinoid abusers. But once you manage them, they're no longer abusing, they're still using. And it almost feels like, and you folks know the literature, there's just not a lot out there about this, but it almost feels like they've gone from this abusive pattern to a pattern where they're actually using medical cannabis as a medical treatment. Now, there's no reason to buy that story, particularly in the literature, but my own personal experience, and take that for what it's worth, seems like you have patients who are gaining benefit. There are a variety of ways you see it. We collected a database on a medical cannabis company, and what we found is reasons people chose it. Number one was pain, which is not a shock, and there's a fair amount of literature about potential value there. But number two was anxiety, and number three was insomnia. And when you look at those two factors, the CB1 receptor is highly linked to those. And so one of the things I've come to think about is, in a way, medical cannabis could be somewhat like a long-acting stimulant, where using something like orosmethylphenidate in a lot of studies Tim was talking about in a way to almost manage short-acting stimulants might be equivalent to managing cannabinoid use, let's say as an oil or something, a less abusable form like smoking, and really managing the quality. And I'm just curious whether you can see, whether you see this as a separate issue and whether you think this might be an approach to where we go.
So
I like the way everybody looked around going, I don't want this, I don't want this, I want this.
Yeah, we're all like backing up slowly.
Yeah, and you were the guy who backed up slowest, so.
Yeah, no, so I guess I would say is partly it's hard to unpack wholly. I'll say one thing is that we've gone from this idea, is there legalization or not, to how do we understand management in the context of medicalization and legalization. So I mean, it's sort of a foregone conclusion in a lot of ways. Yeah. So it's a different context. What I would say is, of course I'm a researcher, so I'm going to want more precision. And when we say medical cannabis, it doesn't necessarily mean any specific reliability in dosing or constituency.
And quality control, like what are you getting?
Oh, there's great variation in quality control, yeah. So that's, and there's been studies where they get off the shelf and there's not good quality control, but I don't want to get too perseverative on that. I think the challenge is that there are potential ways where quality control and some honest brokering of who might be a candidate
Absolutely.
And who might be more at risk. And I think that's corrupted to some extent when it's a capitalistic model where profit drives most of the recommending, and that's part of my challenge. And again, we could take a big, wide look in terms of what we do in general in medicine and how much is ethically driven, profit driven, et cetera, but I think specifically this, one of the things that I'm challenged by is a lot of it is driven by the desire to make money, and a lot of complex issues get oversimplified. But I can sort of say, as part of what we have to do is embrace the idea that this is happening, and we have to manage in that context. And there may be pockets of situations where I think we have to be honest and think about what you've suggested. And I'm curious about how other people take this.
Yeah, I mean, this is a whole huge other topic. I mean, I'm involved in a study right now that Chinazo Cunningham is doing in the Bronx, and she's evaluating what happens to people's opiate use as a result of being on medical marijuana. And the idea is maybe if they're treated with their pain with medical marijuana, their opiate load or opiate use will go down, because there's a lot of data suggesting it might help. But when you look at all of these medical dispensaries, at least in New York, I mean, they have like lists of 40 or 50 products and all different levels of THC to cannabidiol. I would argue that the products that have more cannabidiol in it might be more useful for anxiety or, psychosis it's been promoted for. But, I think that it gets very complicated to say, does marijuana help with these disorders because of the variance in the cannabinoids? But I think it's something that should be studied, and the hard part is actually getting federal funding to study it, because these have been Schedule I drugs. One of my colleagues at Columbia is studying taxane-induced neuropathy with cannabidiol products, and it's been a bear for her to start that study. So I think there just needs to be a lot more research. Certainly nabilone and dronabinol are both products that are available, the THC, that are federally controlled and FDA-approved indications for them.
But the ratio may not be, that's the issue, right?
Right. I think the ratio is a big issue. So I want to make sure other people have time to talk, so I'm going to shut up too, and then maybe the next person. Okay.
Hi, I'm a clinical psychologist, and I treat both children and adults, and I specialize in ADHD and autism. I'm fully on board with recommending CBD, and I've written letters for medical marijuana for my adult patients for post-traumatic stress disorder, anxiety, sleep issues, pain disorders. Where I'm having trouble is adolescents who come in who are using weed in to varying degrees, and parents are not on board. And I don't, again, same as everybody else has said, I don't want to have a power struggle about that, and I use a lot of motivational interviewing techniques. I'm primarily a CBT clinician. I do a lot of mindfulness kinds of things, and I usually will approach things according to how that kid is presenting and what the most important issue is. And I also have a kid who's 17 who has ADHD and a lot of motivational issues, who now has had an episode of depression, and I found out has been using marijuana a lot. So I've also been going to ADHD-specific psychiatrists and psychologists who have both said to me, pick your battles. He's not drinking very much in front of him. And so essentially they gave him the go-ahead and undermined my parenting. And so my question is, and I have another one in addition that's related, but my question is, as a clinician, I don't know where to draw the line between when I might refer out to substance abuse treatment, because I'm not a specialist, for adolescents using marijuana. And I'm also frustrated with I feel like, in the field, our hands are tied, because there's so much positive stuff out there about marijuana that kids are using left and right, and I don't think we know how much they're using, and I don't feel that the clinicians treating my kids have felt empowered to address it, and I don't feel empowered to address it with my patients necessarily. So, my question with that regard is, at what point, at what level of use would you recommend that I send out?
What level of use is safe?
Yeah.
In a harm reduction model.
And along that same line, another question that's related is that some of the imaging studies that are, a little bit of stuff that's out there, is it causing damage to brains?
Let me get the question out there.
Yeah, go ahead.
Go ahead.
So the first is that we'll never get to a point where we can objectively say this much use is safe. Right. Just use less than this. So what I would say is you can acknowledge use without sanctioning it, and I think it's going to be up to your own comfort level and your availability and what it's more subjective than objective as to when you refer out. And the other part is that you talk to rural practitioners, they got nobody they can refer to, so they just got to do it all. And so it depends on what's available to you, because I will also tell you on the other side, there's lots of addiction providers who kind of say, oh, marijuana, pff. So they oftentimes don't deal with it, in part because, well, it's just like, well, we're dealing with some stuff with real mortality risk right now, and we'll get to that later. There's a long history of doing that with tobacco, and now a lot of that with marijuana now too. So I don't have a way to answer without being long-winded other than it's really subjective. I certainly would urge practitioners not to do what happened to you as a parent, is where there's this sort of mixing of messages.
We've gone back in later sessions and addressed it.
But I
to
think,
to
again, I think there's a
clarify.
fine line of where you can acknowledge and tolerate use while you're working toward a behavioral change without sanctioning it and saying, well, one battle at a time. I'm a fan of saying we have to do some things in parallel. But again, I don't want to overtalk.
No, that's great. I want to get another question. Tony?
Thank you.
So the other, first of all, great panel. I think there was a couple of themes that we didn't quite get to, which is across these different substances, why do people with ADHD find them so helpful? And is it performance enhancement? Is it pain reduction? Is it anxiety reduction? Is it anger management? I mean, I think each of these really are wonderful ways of thinking about the complexity. One thing you didn't talk about, which suddenly became an epidemic, which was Yule and nicotine. And I've been seeing a rise in this and been worried about it. When now, of course, it's the horses are already, the fire, whatever. The
Horses out of the barn.
exactly. But
metaphors are mixed,
but
yes.
I do think when getting back to what Tim was saying, if the and you had mentioned expectancies. It seems to me that there's an underlying message across all of these, which is drugs can make your life better, okay? Better living through drugs. And there's a sense in which that has to be true. Otherwise, alcohol and all these other things that we use to alter our consciousness wouldn't be problems. We would just use them the right way. It's something more goes on. We start with this intention. I'm just going to get a pain medication for a little while. I'm just going to use my roommate's blah, blah. And then the next thing that happens, and this is to me where I think we need to move, is warning signs for problematic use. Because I really think that stopping it in the beginning is always best, but there are those group of people who are going to use, no matter what, those things that are available to them, which in our culture happen to be alcohol, nicotine, caffeine, and now increasingly stimulants and weed. And I just think we have to see this as the changing context for adolescence. And how do we as researchers, clinicians, but most of all, talk about to our ADHD patients who I think have not only immaturity, and going back to your, I love Steinberg's in Philadelphia, Temple, and that dual model is great to think about, but I actually think that clinical patients don't buy that. Because if my friends can smoke, or if my friends can use the stimulants to stay up all night or kind of snort, and snorting is huge problem, then getting across the idea that no, you know what? Your brain is a little different. I hate to say it, but you're going to have to face that sooner or later, maybe before or after you have a crash or get busted, or whatever. So thank you. It's a couple. Question about nicotine, though, because I really worry about this, the Juul and the other insufflated forms of nicotine.
Right. I think those are great comments, and I'm just going to comment at the end, and then maybe people can come up afterwards. But I mean, I think that's very true, and I think that one of the people that sort of gets poo-pooed a little bit, because he's a psychoanalyst who does research, or at least talks about psychiatric disorders and substance use, and the self-medication model, which has sort of been disavowed, which I don't think it should, is Ed Kanzian's work. And I'd recommend people read it. He's a psychoanalyst, but he's a very practical psychoanalyst. And a lot of what he talks about is the use, why do people use drugs, and one of the, particularly in psychiatric populations, and it's about affect dysregulation. Some of the terms that you hear with psychoanalytic literature and issues of problems with self-care and irritability, and that, because a question like why do people with schizophrenia use cocaine, besides the fact that they feel good like everybody else maybe, but there's a lot of anhedonia and other symptoms, even in spite of the fact that they get more psychotic. And so despite the fact that people with ADHD may do worse in school or whatever else, there's something that they're getting from these drugs that maintains it besides the physical addiction. So I think your comment is really well taken. It's hard to study, but we see it when we talk to patients. So I think it's really important. I hope this has been of interest to people. I'm sorry we're going to have to stop because we're running out of time. We've had a lot of time for questions. If you have questions at the end, please come up. And I'd just like to thank the panelists again, because some of you have never been here before.